Hello and welcome everyone to today's learning series. My name is Jimmy Twin. I'm the Research Communications and Translation Manager at ISCRR, which is the Institute for Safety, Compensation and Recovery Research, a joint initiative between Monash University and WorkSafe Victoria. Firstly, I'd like to acknowledge the people of the Kulin Nations on whose lands many of us are based today. I pay respect to their elders, past and present, and we extend that respect to the First Nations people here today. For those of you who are new to this learning series, each month we present a topic of our research findings, impact from our research, and learnings about best practice management of research. You can find out about future events by ISCRR by joining our mailing list. You can join for the evaluation survey that'll appear at the end of this session, and also there'll be an opt-out link included when we circulate the webinar. Now, ISCRR has been around for 13 years now, established in 2009, and one of our longest standing collaborative partnerships has been with our speaker today, Professor Alex Collie. In fact, Alex was our CEO from 2014 to 2017. Alex is now Professor and Director of the Healthy Working Lives Group and Co-Director of the Division of Public Health Services and Policy in the School of Public Health and Preventive Medicine at Monash University. He holds an Australian Research Council Future Fellowship, in which he is leading research on health outcomes and care provision for people with work disability and studying the intersection of workers' compensation and social security systems. Alex has a very accomplished career in research. He is an applied public health and policy, social policy researcher with a focus on work disability, workers' compensation, and injury recovery. He leads a number of large multidisciplinary and multi-institute research projects funded by the Australian and international grant funding agencies, workers' compensation, and occupational health and safety regulatory authorities. Alex holds a PhD in psychology and has published well over 200 peer-reviewed research articles, book chapters, and technical reports. Today, Alex will be talking to you all about the fascinating topic of leading indicators, which are aspects of workplace activities which contribute to the risk of future injury or illness. Alex's team led an initial test and a validation study of a leading indicator survey questionnaire involving over 2,000 Victoria workers. The session today is being recorded and will be available to view on ISCRR's Vimeo channel in the near future. During the session, feel free to ask any questions you may have using the Q&A function in Zoom or in the general chat. Yeah, I encourage those who are talking in the chat just to set that little blue box to everyone so everyone can see your questions and responses, and if you have something to contribute towards a conversation. We'll endeavour to answer all questions that come up today, but we will reach out if you do have any specific topic that you wish to discuss with Alex in more detail at a later stage. Now, without further ado, I'll hand over to our speaker for today's ISCRR Learning Series session, Professor Alex Collie.
Thank you, Jimmy, and thank you to ISCRR for inviting me to come and talk today. I'll just share my screen so you can see the slides that I'll be speaking to today. I hope you're all having a wonderful day. The sun is out in Melbourne for a change. And so it's looking at my window here, it's lovely. And I hope wherever you're calling in from, the weather's being nice to you as well. So I'm going to spend the next half an hour or so really talking to you and describing this project that we worked on with WorkSafe Victoria, with some support from ISCRR and also from an organisation called Roy Morgan. So it's a collaborative project where the aim has been to develop and run sort of an initial validation study of a leading indicators questionnaire, with the aim really of increasing our ability as a state to identify workers in Victoria who have an increased risk of being injured or becoming ill at work. Clearly, that's an important thing. We need to be able to measure risk in order to intervene and reduce risk. So when this project became available to work on, we jumped at it at Monash. We think this is a really valuable initiative and a very important thing to be working on. So that's one of the many reasons I'm very pleased to be able to share this with you today. There's been quite a lot of people involved in this project. The funding came from WorkSafe Victoria through ISCRR, so thank you very much. Another organisation that had a big role in this project was Roy Morgan, the social survey company who collected the data. Our research team had many of my colleagues who have worked on this issue of leading indicators over a number of years. And Melbourne and Monash University in particular within Melbourne has been a centre of activity in the development of the science around measuring leading indicators. And so people like Helen DeCherry and Sharon Newnham and Deborah Glass have been particularly active in that field. And this was a really good opportunity to collaborate with those people and put our collective minds to the task here. And I will just say, just to note that what I'm going to talk about today are clearly my opinions, not those of the funders of this study or necessarily ISCRR, although it's lovely to be invited to come and talk to them by those two organisations. A little bit about my group at Monash called the Healthy Working Lives Research Group, just to orient you to who we are and what we do. And thanks, Jimmy, for that introduction before. We're a group that really looks at the relationship between people's work and their health. And our reason for being is to try to get workers and workforces and workplaces into this virtuous relationship where good health leads to good work and good work contributes to good health. And we think the more that we can do that as a society and as a community, we're going to reap the benefits of that, both as individuals in terms of our health and economic outcomes, but also as a community in terms of productivity and social cohesion, less health expenditure, those sorts of other community benefits of getting into that relationship. Our group runs a range of projects. This one is firmly within our prevention research program. We also have programs of research on recovery and also some looking at systems such as workers' compensation systems. And we do a lot of teaching and education, including research training and postgraduate courses and some short courses as well. And some people involved in the group you can see on the screen there. Lovely group of people to work with. Okay, so as Jimmy mentioned, leading indicators are measures of things that put people at risk of workplace injury or illness. They are, sorry, I've just been distracted by the chat there. They're very different to lagging indicators. So what we typically measure, what we routinely measure in society, in occupational health, what I would call lagging indicators of injury, illness, and the consequences of those injuries and illnesses. So they are things like the number of injuries and diseases, the type, the rate, the amount of time people take off work, the healthcare provision, things like fatalities arising from injury, illness, or hospitalisation. They're things that we tend to capture in pretty well in structured data sets and in systems such as workers' compensation or healthcare data sets like hospital data sets. Leading indicators are not things that we capture routinely. They're things that put people at risk of illness and injury, and they're more challenging to measure. The concepts themselves are a little bit more tricky to get one's head around, but they include things like the demands in your job, whether you work in a very demanding job or less so, the amount of control you have over your activities within your job, what's called the safety, sometimes called the safety climate or culture of the organisation that you work in, the amount of exposure you might have to physical or psychosocial hazards in the workplace. These are the sorts of things we're talking about when we're talking about leading indicators. And in the last decade, there has been a real growth in the science around leading indicator measurement, including the development of a whole raft of different questionnaire-based tools for workers and workplaces to try to measure these sorts of things. I've included on the screen here just one report of the many that have been published by some international sort of regulatory authorities. This one from the Occupational Safety and Health Administration in the US from a few years ago. And our job really in this study was to try to develop a questionnaire, a survey-based measure, using that existing science that had been established and making the most of the existing questionnaires that had been developed and published around the world, and trying to validate those things for use here in Victoria. So the purpose of the project was to do that, was to develop and then run an initial test of a leading indicators questionnaire. And really the reason for doing that is because we wanted that questionnaire to be able to enable us to identify workers who were exposed to risks that put them in harm's way. And we anticipate that if we can get to the point where we have a question that can be used routinely, we'll be able to use that for a number of purposes. So it will enable identification of groups of workers in industrial sectors or in cohorts based on occupation or demographic or other characteristics who are at increased risk of work-related harm. It will give us a new source of data, a very valuable new source of data that can help regulatory authorities and employers and others involved in preventing injury to design new or modified solutions to prevent risk and reduce the risk of future harm. And it'll give us more insight as well if we understand these relationships between the nature of work and the risk of future injury, illness. It'll help us to build insights into changes in the workplace that we can put in place or that others can put in place to reduce risks in Victoria. And so some really important reasons for doing this. I'm going to spend most of today talking about the findings of the project, but I'll just touch briefly on the method. And we ran this in three different stages. The first stage, we developed a questionnaire that was then used to collect data, and from which I will report the findings. And I'll talk a little bit about how the questionnaire was developed in a second, but it involved a fairly extensive literature review and expert input from people around the world who've been working on this topic over the last decade or so. That was our job at Monash, working with WorkSafe Victoria. And then we sort of passed the baton to WorkSafe, and Roy Morgan, helped them a little bit to finalise and refine that survey. But Roy Morgan then went out and collected the data using that questionnaire in a sample of just over 2,000 Victorian workers. And then they handed the baton back to us, and we picked up all that data and we ran the analysis and reporting on it. And that's mostly what I'm going to spend my time talking about today. A little bit on how the questionnaire was developed, because I do think it's important that you understand how this thing that we're using to collect data came to be. We spent a bit of time doing a systematic literature review, looking for leading indicator measures, surveys, questionnaires that had been published in the academic or other literature around the world over the last 15 or 20 years. And we did that through searching electronic databases, and we also reached out to a range of experts in Australia and internationally who we knew had been active and working on this topic. We compiled that into a long list of potential measures that we could include in a survey-based questionnaire that could be administered online or via a telephone-based survey. And we then applied a set of what are called occupational health surveillance criteria to turn that long list into a short list. And we wanted to make sure we were selecting measures for inclusion in the survey that had certain characteristics. We wanted to know, for instance, that there was evidence that they could predict later injury or illness, given that that's one of the key purposes of leading indicator measures. We wanted to know that there was evidence that they were reliable, that if we administered, that means that if we administer them on 2 occasions to the same group of people, we'd get the same outcome, assuming nothing else had changed in between. And so we applied those sorts of criteria, and that allowed us to identify a short list of 5 measures, which I'll show you in a minute. And then we also added into the questionnaire a few other things. Because we're interested in looking at the relationship between scores on these leading indicator measures and injury and illness, we had to identify and include some questions about injury and illness, or what we'll call lagging indicators as well. And we're also very keen to identify features of workers and workplaces that meant they were more likely to be at risk on these leading indicator measures. So we chose a few questions and items about workers and about their workplaces and jobs. And we did that through reviewing prior surveys and again with expert input. We put all of those three things together and we end up with a draft leading indicator questionnaire. And the questionnaire has really three components to it. The first component is a set of items asking about the person or the worker and their workplace and their job. I'll show you some of these features as we go rather than talking about them in detail now. The second component is the main part of the questionnaire. It's these 5 leading indicator measures that we shortlisted, and they're listed on the right-hand side of this slide. And the third section is a short set of items on lagging indicators, so questions about physical injury, mental injury, near misses in the workplace, those things that we sort of traditionally use and measure in occupational health. You can see the list of 5 leading indicator measures here on the right. I won't go through the names, as is typically the case with these sorts of academically developed questionnaires. They have sort of strange names. At times strange names. I don't quite know how some of these things come to be. I will use the abbreviations for some of these as we go. I'll try to remember to actually give the full name as when I can. And I've also just listed here the number of items in each of these measures. So that's really the number of questions that each of these measures contains. And you can see it ranges from 3 up to 27. Here's an example of one of them, just to give you a bit of a flavour of what these questionnaires actually are. This is the first one, the Psychosocial Job Quality Index. This was actually developed in Australia from HILDA, which is a big longitudinal household survey conducted, led from the University of Melbourne. It's been going for about 20 years. It's been used extensively. And this measure was developed from some questions in HILDA. There are 12 items. You can see they ask about job demands and job complexity, job control, security, and what's called effort reward fairness. And so we can break this 12-item measure down into 4 subscales on each of those components, and we can score people on each of those 4 subscales. It's been used pretty extensively, as I mentioned. And the other measures are sort of similar. Some of them, particularly the long ones, have subscales. The short ones don't have subscales, obviously. And I don't have time to go through all of them with you today, but I just wanted to give you a bit of a flavour for one of them. You can see the questions are pretty straightforward, and people are asked that question and then given a very simple response framework. So these are things that can be administered to large groups of people fairly rapidly using things like telephone surveys or internet-based questionnaires. Okay, so in terms of data analysis, once we had received the data from Roy Morgan from the administration of that survey to over 2,000 workers in Victoria, we went through a few steps. We spent a fair bit of time preparing the data. It was very good quality, but it did require a bit of cleaning and quality assurance, and we had to calculate things like risk scores and categorize variables such as occupation. People told us what job they had, but we wanted to turn that into categories that we could then use in analysis, for instance. We then calculate some descriptive statistics, and I'll show you some of those. So we look at the characteristics of the sample, and we explore the outcomes on each of those 5 leading indicator scales across the whole sample. We then look at the relationship between characteristics of workers and their jobs and workplaces, and whether people are considered to be at risk on these leading indicator scales using a chi-square analysis. And then we run some logistic regression models to look at the association between scores on the leading indicator scales and our lagging indicator measures, which are measures of actual injury or illness. I'm going to run you through each of these things and give you a bit of a flavour of what we find in this analysis. So first of all, who completed the survey? Well, just over 2,000 Victorian workers completed the survey, 2,053. As I mentioned, there were 5 measures of leading indicators in the scale, and we got people from a pretty broad array of jobs, industries, and social backgrounds. Our sample was pretty much evenly split between people who reported their gender as male or female, with a small proportion of non-binary people. We had sort of, probably compared to the Victorian labour force, probably a larger group of people in the 25 to 44-year age group than we would see in the labour force. So the the age distribution was slightly different to what we see in the labour force, but again, because it was a pretty large sample, quite a lot of people across the age range, which allows us to test and look at the effect of age. Our sample was pretty well educated, again, a bit more highly educated than the labour force. About 57% of people reported having a bachelor's or a postgraduate degree. You can see that more than 1 in 5 were born outside of Australia. 8% almost reported a disability. In terms of the industries that people came from, it actually represented pretty well what we see as the distribution of industries in the labour force. And so the largest industries in our labour force were well represented in our sample. And people came from a wide variety of occupations, lots of people in professional, managerial or administrative roles, probably less in more sort of what we would traditionally call blue-collar roles, I guess. And this partly reflects some of the challenges in getting people in those sorts of roles to be involved in survey-based studies like this. Really interestingly, we asked people where they had spent most of their time working in the last week, and the data was collected towards the end of 2021 as we were emerging from the COVID wave, and a lot of people were still working at home. And you can see about 44% of people reported that the main work location for them over the past week had been their own home compared to their employer's work site. And I think if we had done this survey a few years ago, we would have got quite a different response to that. And there have been times during the pandemic when we might have also got a different response. But clearly that's an important thing to consider when we're asking people about risks they encounter in their workplace. If you're working from home, those risks are likely to be quite different to if you're working from an employer's work site. And so keep that in mind as I'm describing some of the findings. Okay, so the next thing we did was calculate on each of those 5 leading indicator scales how many workers were at risk. And the high-level summary of this is that between 1/4 and 1/3 of workers self-reported using these questionnaires what we would consider things that would put them at high risk for a future workplace injury or illness, and it varied depending on which measure we used. So you can see here that on the psychosocial job quality index, we observed that 26.4% of people were at high risk using the sort of statistical criterion of future work-related harm, up to about 36.5% on the OHS vulnerability measure. Now, interestingly, the way we calculate risk on each of these measures is a bit different. So there's a surprising consistency in one sense between the proportion of people, regardless of the fact that we're using different measures to measure risk. I'll just explain how we measure it using an example. So this is using the psychosocial job quality index that I showed you just before. It has 4 subscales. Those 4 subscales are shown on the left-hand side here: job demands, job security, job control, and effort reward fairness. And people get a score on each of those subscales depending on how they respond to the questions. And we turn that into a score of 0 or 1. So if you look at the job demands subscale in the upper left-hand side, people whose score is in the red band there would get a score of 1. People whose total score on that subscale was in grey would get a score of 0. And then we add those 4 subscale scores together to give people a total score of between 0 and 4, which you can see on the right-hand side. And anyone reporting a score of 2 or more on this, we consider to be at high risk. That's the way that this particular scale has been constructed and the way it's scored. It's a little bit different on each of the different leading indicator measures that we have. The way of determining whether someone is at risk varies slightly. This is just one example. So we go through the process of calculating the subscale scores, and then we determine the total proportion of people in the population who are at risk using those scores, and what we get are these figures of between 25 and 36%. We also then use that as an outcome and to try to look at the characteristics of people who do score in that high risk zone on each of those different subscales. And what we observed when we do this was there was some consistency in some of the markers or the characteristics that put people at risk. So we observed fairly consistently that people whose household income, not necessarily their personal income, but their household income, was less than $1,500 per week were more likely to be rated as high risk on these scales. We see people from some industries, so the retail trade industry and education and training industry, being more likely to be considered high risk. We see people who report having multiple jobs or working for multiple employers, maybe indicating a variety of different workplace exposures and working circumstances, and maybe an indicator of sort of precarity of work, also being at high risk. And we see government workers consistently being rated at high risk. On each of the subscales, there were some other markers that also indicated the people at high risk, but these were the things that came through fairly consistently. Now, I mentioned that we also measured lagging indicators. I'll just describe the high-level findings for lag indicators briefly. So we asked people about psychological health or mental injury, we asked them about physical injury, and we asked them about near misses in the past 12 months. We had a number of other measures of lagging indicators as well, but I'll just focus on these three. And you can see that 24% of people in this sample reported some form of mental injury in the past 12 months. 19% reported a physical injury and 18% reported a near miss or an event in their workplace in which they were almost injured or almost became ill. We'll look at these a little bit more closely. Physical injuries, the most common physical injuries were musculoskeletal conditions, including things that we commonly see in other occupational injury data sets like back and neck pain, arm and leg and shoulder pain as the most common sorts of musculoskeletal conditions. So this sort of pattern generally reflects what we observe in other things such as workers' compensation claims data or other injury data in workplace settings. And we see a few other types of injuries as well occurring, such as sort of acute injuries like cuts and bruises or crushing being fairly common, burns being a bit less common, and then a whole raft of other things which are reported less frequently, including digestive diseases, respiratory diseases, cardiovascular infections, cancers. And again, that broad pattern reflects what we see in other occupational injury data sets. Mental injury or psychological health conditions, what we see is that nearly a quarter of the sample reported something in the past 12 months. And again, the most common things here were stress and anxiety, followed by depression and then post-traumatic stress disorder. And again, this pattern reflects what we see in other injury data sets, such as workers' compensation claim data, where the most common reasons for making, for instance, a psychological injury claim is often stress and anxiety, followed by depression and then PTSD. So this is a pattern that we would expect to see. What we do then is we look statistically for the relationship between those leading indicators, so whether people are considered to be at high risk or low or moderate risk on those 5 measures, and whether they reported one of those lagging indicators in the past 12 months. And so I'm going to show you a series of slides where we work through a set of analysis to try to figure out whether there's a statistical association between your scores on these questionnaires and whether you report being injured or having a mental injury or a near miss in the past 12 months. And on this slide, what you can see on the left-hand side is a set of abbreviations from PJQI down to PCS12, and they're just the short form of the names for those 5 leading indicator scales. So the first one is the Psychosocial Job Quality Index. And the red bars indicate the proportion of people who are considered to be high risk on that scale, who also report the outcome we're measuring here, in this case, physical injury in the past 12 months. And so if you look at the top one there, you can see that 27% of people who were considered to be at high risk on the PJQI also reported a physical injury in the past 12 months, compared to 16% of people who were rated as being at low or moderate risk. And you can see across all of these 5 leading indicator scales, workers who are rated as high risk are more likely to report a physical injury in the past 12 months. And the pattern is similar across the 5 leading indicator measures, but some measures look like they're better able to differentiate those risk groups. For instance, in this case, it's the one in the middle, the OHS vulnerability measure, where there's the biggest variation between those red and grey bars. And then what we do is we enter this data into a regression model and we adjust that for a range of other things that we know can influence your risk of injury, such as your age, your gender, the occupation you're in, and a range of other things. And we report that back here in what are called odds ratios. And really, the way to interpret this graph is that a higher odds ratio means you are you are more like, sorry, a higher odds ratio means that the high risk group on the leading indicator scale is better differentiated from the low risk group. And a higher odds ratio means that the scale is better able to differentiate people who report an injury or not. And you can see, and a score over 1 is statistically significant. So scores on all of our 5 scales here are pretty good and statistically significant, but we're seeing the highest odds ratios for 2 measures, the OHS vulnerability measure in the middle, and the one at the bottom, the PSC12, the psychosocial safety climate scale. And then we repeat that analysis for mental injury, and we see very similar patterns. So we can see that workers rated at high risk are more likely to report mental injury in the past 12 months. Again, the pattern is similar across the 5 leading indicator measures, but some of these measures look like they're better able to differentiate between groups. We enter that into an odds ratio, and we see that there are a couple of measures here, the top and the bottom ones, the psychosocial job quality index and the psychosocial safety climate measure, which look like they're better able to differentiate between high and low risk groups. And you'll notice the names of those scales, psychosocial in the name, and that's because they measure those psychosocial aspects of job quality. Probably no surprise that they're more related or better related to mental health or mental injury in the workplace. We repeat the same sort of analysis for near misses, and you can see, again, all of the scales are able to differentiate between people who report near misses and people who don't. But some look like they have better ability to differentiate, and here we see it's the OHS vulnerability measure. And so that analysis gives us some confidence that there is at least an association or relationship between scores on these leading indicator scales and whether people report an injury or a near miss in the workplace over the past 12 months. And when we combine that with a literature review, which I mentioned at the start, where we know we have, for at least some of these scales, some evidence that scores on these scales predict later injuries or illnesses, it actually gives us some confidence that these are valid relationships that we're measuring. Just to begin to wrap up, the final thing we wanted to try to do with this initial study was to ask whether we can refine this questionnaire. So we had 5 measures plus a range of other questions. It took 20 or so, 25 minutes to administer that questionnaire to each person on average. So it's a fairly significant burden of time or amount of time we're asking of people to give us. So we wanted to see if we could get good quality information in a shorter period of time, which would enable it then to be used more broadly across the population or across large samples of people. And so the way we did that was we looked at some of the features of each of these 5 scales, and we ended up recommending 2 of them for use in future studies, being the ones highlighted here in blue, the psychosocial job quality index and the OHS vulnerability measure. So for instance, we looked at the percentage of people who we asked to complete these measures who were able to complete the measure. And on 2 of the scales, that was 100%. On others, it was less than 100%. And the reason for that was because some of these scales are really not, the questions don't make sense for people who are sole traders, because some of the questions are designed for questions about your workplace, or they have questions about your work colleagues. And if you work by yourself, those questions don't make sense. So on some of these measures, we were sort of excluding 10% or more of the sample because they were sole traders. We looked for the number of associations between worker and job characteristics and the outcomes on the scale, and more is better here. We wanted our measures to differentiate between more of those characteristics. We looked at the statistical association with the lagging indicators using those odds ratios, and these 2 scales that we are recommending had quite strong associations, and one of them had a strong association with mental injury and the other one with 2 other outcomes. So we think they complement one another. And we looked at who was rated as being high risk on each of the scales, where less overlap is better, so that we can identify discrete groups of people. There was quite a lot of overlap, but the The ones with less overlap were the two scales that we recommended. So what we're doing at the end of this study is actually suggesting a refined version of this questionnaire for use in the future. Very briefly, just talking about those two measures that we've made some recommendations about. There's a lot of prior research on these. So the OHS vulnerability measure has been used a lot. It was developed by a fellow called Peter Smith, who some of you may know. He worked here in Victoria for a while. He's Australian, but he spent most of his career in Canada. He's now the president of the Institute of Work and Health over in Toronto in Canada. And Peter and his colleagues, including some colleagues here in Melbourne, have published a wide variety, a number of studies looking at the characteristics of this OHS vulnerability measure. I've just put a couple here. The results are very consistent with what we observe. About 35 to 36% of large groups of working age Canadians are considered vulnerable or high risk. And in these studies, Peter and his colleagues report significant associations between risk and injury. And also some of the same things that put people at risk are observed in these studies as what we see. So a fair degree of consistency between what we're seeing in this study and what has been observed on this measure in other studies. And the second one that we're recommending for use in the future is this thing called the Psychosocial Job Quality Scale. And here's, again, that's been used a lot in a whole variety of different studies. Here's one example which looks at the mental health benefits of moving from unemployment into employment. And typically what we hear and see talked about in occupational health is that moving from being out of work into being into work is very good for your mental health. And on average it is, but this study actually gives us a bit more nuance to that insight, and shows us that moving from unemployment into a job with good psychosocial quality leads to quite significant improvements in mental health. But moving from unemployment into a job with poor psychosocial quality can lead to declines in people's mental health. So that's sort of an important insight. So that's really just to show you that these tools that we're recommending are widely used and have been validated in a range of settings, and we think can be very valuable for helping us in Victoria to identify people at risk. So a quick summary of the project outcomes. So essentially what we've done here is developed and tested leading indicator questionnaire and run some analysis, which we think gives us at least some face validity and a bit of construct validity to that questionnaire here in Victoria. And we've suggested some ways of refining that for future use to make it more palatable for more widespread use. This is really a beginning. It's certainly not the end of this process, but it is an important beginning. We need to get further evidence to really validate and show that these sorts of questions can be really helpful in very practical ways. So we think it would be sensible to do things to run a longitudinal study to determine the ability of this particular questionnaire to predict later injury. We think it would be sensible to run some more reliability analysis to look at, to make sure that each time we use it, it's measuring the same things. And there are some challenges in reaching some aspects of our workforce, our labour force, people in certain occupations or with certain characteristics who are hard to reach and hard to survey with these sorts of measures, be it online or on the phone. And it's important that we understand or we make sure that this questionnaire can be applied in those people, because they're also often people who are more likely to be injured or ill. And then, of course, we need to figure out how this works in real life. So if we apply it, we identify a group of people who are at risk and we intervene. And does that make a difference? That's a really critical question to sort of look at ultimately how useful this is. So there's quite a lot of work left to do to validate the use of these tools, but this is a really good start. Finally, just to wrap up on the so what, to bring you back to the start. So why we started this, why would you want to collect leading indicator data on a sort of regular basis? Well, we think you'd want to do it because it can help government agencies and employers and others involved in occupational health and safety to do three things. First of all, identify groups of workers and workplaces who are at high risk for later harm. If you use it regularly, we think you can monitor changes in workforce risks for work-related harm over time, and that can allow you to focus your energies on those parts of the labour force that are going to benefit the most. And then by understanding risk better, it can allow us to target work health and safety prevention activities to those areas of greatest need. So that's really the argument for why we would want to do this. I'll leave it there, and hopefully there's time for questions. Back to you, Jimmy.
Thank you, Alex, for that great presentation. We do have time for a few questions, and quite a few questions have come through. If your question is not answered today and you do want follow-up, feel free to leave your details in the survey that will appear after you leave today, and we'll follow up with you. The first question, and I'll start with a fairly straightforward one first. How frequently do you think that this type of questionnaire should be performed?
Yeah, well, great question. I think that's probably something we need to establish, but I guess I would say I would like to see it used routinely. Yeah, there's some costs involved in sort of administering these questionnaires on a large scale, so we need to balance, I guess, the investment required to get this sort of what I think is quite valuable information. But we measure other things on a regular sort of ongoing basis, such as the outcomes of injury, annually or more often, in order to understand how we're performing in these occupational health and occupational rehabilitation schemes. So there's every reason, I guess, for us to measure these things that put people at risk of injury and illness at least as often as that, I would say. I know the OHS regulators around the country each have different approaches to the types of data they collect and the regularity over which they collect that data, but the more often we collect this sort of information, the better insights we'll have into what's happening and what's changing in the workforce. So I don't have a very precise answer for that. I can't say we need to do it every month or every 2 weeks or every 6 months or anything like that. But you're asking sort of an academic, so more data is always better. But there does need to be a balance between the investment in time and effort and then how the information is used.
Great, thanks for that. We received a comment that came through in the chat that stating that we continually see the same predictable and preventable injuries happening over the past few decades. In your experience, where lies the greatest challenge here?
Well, I think just reflecting on a few other projects that we have been working on recently, I think there's no doubt that the biggest challenge, not just in Victoria, but nationally and in other similar nations at the moment, is actually about mental health at work and about the impact that all of the things that we've all been through over the last few years is having on mental health of our labour force. And I think we're starting to see that in some industries in particular come through really strongly. And so, it'd be no surprise to anyone, I guess, on this webinar to think about healthcare and social care as an industry where we have been seeing a sort of rapid growth in mental health challenges of those particularly frontline workers, and particularly people in some occupations. And there's so much pressure on people in those industries at the moment, and preventing that probably requires redesign of those jobs and redesign of those workplaces, because what's putting people in that situation is the job itself. And so we need to carefully consider how we organise and design those jobs. And so there's some really very significant challenges, I think, in our labour force for that. And then we've also seen pockets of other things occurring. We've had all sorts of interesting and distressing issues arise over the last decade, things like silicosis in coal miners and in benchtop stone workers, those sorts of things coming up in sort of specific industries or jobs. So, but I do think if you look at it at a population level, the mental health issues are the largest. I would agree that broadly at a high level, the same sorts of injuries and illnesses are occurring. but it is changing slowly, and the most significant change, I think, has been in this increasing recognition of mental health conditions as being of growing concern.
Thanks for that, Alex. So the next question, you care to just explain a bit further what your definition of injury was? Was it injuries that required first aid or medical treatment, or was it through self-reported only?
Yeah, so this was a questionnaire completed by workers, so it's all self-reported data that we've got here, and it's one of the limitations of the data is that it's self-reported. We actually asked a lot more detail than I presented in the questionnaire. What I presented was just very high level. Have you experienced any of these injuries or illnesses on a list over the last 12 months, sort of a yes or no list. We also asked people about whether they had had time off work for that injury or illness. And so we do have in the questionnaire, which I didn't report today, some information about whether people required time off work for the injury or illness, and a few other questions as well. But it is self-reported. And so what we tend to see when we ask people those sorts of questions is we get a higher estimate of the number and proportion of people who have been injured or become ill than if we look at other data sources. So much higher than we would see in workers' compensation claims, for instance, because we know a lot of people aren't eligible for or don't make those claims. Much higher estimates than we would see in other data sets like health service data sets where people are seeking healthcare for those injuries and illnesses. So there are some limitations to that.
Great. For the next question, that have you done or planning any comparisons with claims data collected per industry?
That wasn't really the purpose of the study. It's a really good question in that what we know about claims data is that there'll be a lot of people who are exposed to harm and risk in their jobs or at work who aren't injured or don't become ill, and then there'll be people who are injured and become ill who don't make a claim. So there's a few steps between what we're measuring here in the leading indicators and what we see as a lagging indicator in the claims data and the outcomes of that. So at an individual person level, it's actually quite challenging to link those things together. We'd have to have an enormous sample of people in order to follow some of them through to workers' compensation claims later down the track. It would be a very, very large undertaking, which would be great to do, but it would just take a long time. If the question is about looking at this at sort of industry-wide trends, then yeah, that would be possible and feasible, I think, to look at the sorts of risks that we're seeing in particular industries and whether they translate at an industry level to the sorts of injuries and illnesses that people are reporting in claims data. We haven't done that. It would be an interesting thing to do.
Thanks, Alex. So we only have time for one final question. There's many other questions that come through, so we'll possibly send you through these questions, Alex, if you want to provide a few points. And when we circulate this video stream and also the links to the reports, you'll have more of the answers there. So I guess to finalize, in your presentation, you reported that 2.4% of the workers experienced PTSD during the last 12 months. That number seems quite high. Was there any analysis to characterize this group?
No, there wasn't. Again, the main purpose of the study was not really to focus on those lagging indicator measures, such as the types of mental illness that people were reporting. I would say I don't think that is, well, I guess across the labour force it is potentially high, but I'd have to probably do a bit more exploration of other data sets to understand what the population prevalence of PTSD is in workers. We did have a large group of participants from some industries where we know that PTSD rates are more elevated, such as in the healthcare industry. So, for instance, in ambulance officers who are part of that healthcare industry, PTSD in some states is the #1 reason for making a psychological injury claim. So I can't really comment on whether it's high or not, I guess. And it really wasn't the purpose of the study. We were using those measures as outcomes to try to validate the leading indicators in this study.
Thanks for that, Alex. And I think I'll just close off with a comment that we received in the chat that someone's talking about the challenge here is refining and developing the predictive information to really zero in on the individual workplaces or roles where industry is most likely to really focus prevention efforts. Even if to narrow to the riskiest 10% of workplaces, that's more than 25,000 locations in Victoria. So really hard to get across to everyone from the prevention viewpoint. So there's encouragement, please keep refining this process because with effort, the analytics will get us there.
I agree. I mean, as I said, there's a lot more work to be done here. This is a start, and we're heading in the right direction, I think. Yeah, I couldn't agree more with that. When dealing with population level challenges like this, we need to make sure we're using the best information to intervene. And I think this is a step in the right direction, but lots more to be done.
Once again, thank you so much, Alex, for the discussion today on leading indicators. And thank you all who've participated in the conversation, the chat, and asked questions.